Well, it's 12:30. Welcome. My name is Gina Clonin, founding president of the Connecticut Women's Hall of Fame. For nearly 3 decades, the Hall has worked to discover and share the stories of women. Our various educational platforms acknowledge the individual and the collective feminine voice. This will be a half-hour intimate and informative chat, followed by 15 minutes of your questions, which we encourage you to submit at any time during the webinar by simply clicking the Q&A bubble at the bottom of your screen. We'll try to get to as many as possible. Our goal is simple, a virtual gathering to talk about today's important issues. We hope this will be a useful source of information while offering up helpful takeaways. I am so honored today to have as our guest a premier researcher and practicing physician with 43 years field experience. In 2014, she became Yale School of Medicine's first female and African-American full professor of radiology, biomedical imaging, and neurosurgery, while also serving as director of interventional neuroradiology at Yale. Please join me and welcome Dr. Michele Johnson.
Hello, everyone. Thank you so much for joining us today.
And
thank you so much, Gina, for the invitation.
Oh, I'm honored. So the national theme for 2022 Black History Month is health and wellness, acknowledging the legacy of not only Black scholars and practitioners in Western medicine like yourself, but speaks to the cultural richness of those non-traditional practitioners like doulas, midwives, naturopaths, herbalists. Dr. Johnson, in your opinion, how do these historical approaches influence Black health and wellness today?
Well, again, thank you everyone for being here today. I'll have the disclaimer that I'm not a historian. I've never been to Africa. I can speak for the Black woman that I am and my upbringing and culture. I think what's important for practitioners of medicine, just as people who are teachers or other people in life, is you encounter other people and you accept them where they are. Find that patient, where are they? And if you can help the patient to interact, if you can help them by appreciating that they have a culture and a point of view, I think that goes the longest way to helping people to be well and to grow.
I think as we were talking earlier today, you mentioned that in all cultures, we have food traditions, we have holidays, we even have superstitions, we have all kinds of things. And to look at that through the individual prism is what you're saying, right? To look at the individual, and when you say where they're from historically, where they're from geographically, where they're from in this moment, right?
That's right. I think it's really important that, a lot of people's self-value and self-worth comes from the fact that everyone believes in dignity, everybody wants to be respected, that it's very important. You mentioned food traditions, for example, on New Year's Day. Different cultures, different families have different things that they eat on New Year's Day that's supposed to bring you luck and supposed to bring you, joy for the coming year. And those can be anything from black-eyed peas to tomato soup, depending upon what your culture is. And so those are just things we should be celebrating our differences.
They can also bring poor health. So we were just talking about the Super Bowl, I'm not sure that there's anything healthy on the American Super Bowl menu, but we all enjoy it.
Mm-hmm. Absolutely. And there are trade-offs, and there are trade-offs both in food and in other things in life, as that we can maintain our traditions and maintain our health and well-being, as that's a theme for us to think about in the month of February this year.
Exactly. The legacy of care for the Black community is, as you well know, blighted by a history of disparity, discrimination, and destruction. From 1619, when the first enslaved people were brought to Virginia, until 1865, when the last enslaved person was emancipated, Black people, especially women, endured violent medical treatment and experimentation against their will. Best examples of that, of course, are the Tuskegee study and the case of Henrietta Lacks. As an African American woman, did you learn about such atrocities in med school?
So yes, these things were discussed in medical school. They were discussed as in fact, things that happened and kind of as a legacy of mistreatment and which breeds mistrust in the Black community. But I learned these atrocities at a younger age in growing up. I knew about the Tuskegee experiment, um, probably before I understood what the disease was all about. You understood what that was. And I think that that legacy of mistreatment and perception is really important. So they kind of cross each other, right? You have this, in fact, atrocities that happened, and then you have now when new medical techniques in the most recently, obviously, the COVID vaccine and concerns about vaccine safety, and I've had patients in the ICU, patients' family members pull me aside and say, are they trying to experiment on my loved one? There is a perception that a mistrust of organized medicine. And I think that when we as practitioners approach patients where they are, to be able to show some cultural sensitivity. And by that, I don't mean you have to know every segment of society's rules and beliefs, but what you do have to do is respectfully listen and try to work with the baseline that the patient and family are presenting to you when they present for care.
And of course, it didn't help at all that there was so much widespread misinformation, regardless of what kind of trust you had in the medical system before COVID. It was constantly being challenged by misinformation on multiple of platforms. So I suppose that certainly didn't help.
Yeah, it's kind of the analogy that, we were trying to fly the plane of COVID while we were building it, while we were building how to treat it, how to prevent it, how to protect ourselves, the virus was running rampant through the community.
Which brings us to that. Okay, so nationwide, Black people have died at 1.4 times the rate of white people from COVID, highlighting the health inequities that have existed for many years. Do you think that this national focus on those inequities might bring change to the quality of care for people of color?
I do think that I'm a glass half full kind of person, but I think that some of these areas of the disparity were going unrecognized by the general public. It was a secret that was not discussed. And I think although there have been some terrible things that have happened in the last couple of years, what it's done is it's raised the consciousness of everyone to think about conscious and unconscious bias, to think about the consequences of racism, to think about that with respect to the people down the street, everything from the people who have the Black Lives Matter signs in their front yard. It's a recognition that all lives matter, and that we can have the conversation the conversation about race and ethnicity and gender differences, and all of those conversations we can have out loud and publicly. And I think the more they see the light of day, the better opportunities there are for improvement in care.
These inequalities, which COVID has shown such a light on, were they in your medical environment? Were they already the topic of much concern? Were they being evaluated? Because for a lot of the general public, unless you're sick or you have a hospital experience, you're not really sure what's going on behind the scenes. And it seems like a lot was happening that many of us were not aware of.
Well, I mean, I can't speak for all of organized medicine either.
Right.
But I think that depending upon what your area of medicine is or nursing, what your role is, you're going to be exposed to a different patient population, and you're going to look at disparities in care or disparities in incidence of disease, just like the disproportionate effect on people of color with COVID. You see similar differences in heart disease or stroke, in different ways. So I think the medical community is certainly aware of those differences, but many of those differences don't just come down to the color of your skin. They come down to many other factors. And in fact, these other factors may be even more important than the color of your skin.
Can you just illuminate for me what would be some of the other factors that feed into this inequality in healthcare? I mean, obviously insurance, but I read a statistic that most Black Americans are insured, very high level of insurance.
Well, I don't know about insurance being the issue. I think that certainly economy has a lot to do with access to care. Mm-hmm. There's some studies recently that have said that the zip code you live in has more to do with the certain aspects of some diseases than the color of your skin. So, the zip code tends to more relate to economy, right? And so it's really multifactorial, and I don't think that we can put our finger on just one thing. I think that speaks to why you have to take the individual where they are, and you have to look at where they are and what's going on with them, and provide each individual with dignity and respect, or respect, so that you maintain their dignity.
Absolutely. Speaking about, change that will come with the attention brought to healthcare inequities, perhaps one sign of change I read was a CDC report noting that over the course of the vaccination rollout, Blacks had been less likely than their white counterparts to receive a vaccine. But these disparities have narrowed. What do you think might have influenced that?
Well, I think the more the message you talked about, the mixed messaging that took place, I think the more the messages became more consistent. Perhaps the inconsistent messages became more polarized, and so people could make decisions. I think the prominence of people who spoke out, for the vaccine, I think that's true. But I know that there was some literature that looked at, again, the zip code, some of the poor Appalachian communities, and the vaccination rates there were quite low as well. And, whether it's economics, education, I think all of those things contribute.
I read somewhere too that one approach that some communities took is, instead of people just getting in line and putting out their arm, they sat and talked to them. What do you know about this? What do you think about this? How can I help you understand it? Because in the Hispanic community, which I have close connections to, having lived in Mexico for many years of my life, they were just misconceptions. They didn't really understand, and they wanted to be valued, as you said, as an individual, to say, what is it that you need to know? What questions would you like to ask me? The person who is going to give them the vaccine, and that in itself increased a lot of the vaccine turnout, because they didn't have a full understanding of what it was, and they were confused by, as you say, the mixed messages they were receiving from all different outlets.
Yeah, that's certainly true. I think that's one of the things that we as a community of people can help by improving education and healthcare education in our community. I have a good friend and colleague, Lakaya Nichols, who is the medical director and founder of an organization, Community Hope Center, here in New Haven, Connecticut. And this organization, and I'm just going to read it so that I get it right, it is to connect healthcare providers to the community to create an alliance that builds trust, promotes healthier lifestyles via health education and continuous follow-through in order to improve health outcomes in the New Haven community, using education, resources, and to facilitate accountability. Here in New Haven, through this organization, in person before COVID and on Zoom after COVID, we've talked about topics like heart disease, stroke, diabetes, nutrition, a lot of things that we can bring men and women together on a Saturday morning for an hour and a half, and talk about a topic and let people ask questions, oftentimes with a couple of speakers. I think most recently I spoke with a nurse, Kathy Tucker, talked about heart disease, and I'm a neuroradiologist, meaning I deal with the brain, spine, and head and neck, and I talked about stroke. And so being able to educate the community with what this means by your symptoms, what this means when you come in for treatment, what this means for your long-term health, and what things can you do to mitigate your risk factors. That's coming from community member to community member, and that's a really powerful way of communicating positive goals and positive and demonstrating positive role models.
Can you repeat the name of that organization? I want to make sure that Michelle from our office picks it up so that we can put it on the website when this webinar is uploaded.
Yes, it's Community Hope Center. It's hopecenterct.org.
Wonderful. hopecenterct.org. I couldn't help but think when you were speaking about that is it's the kind of reform and policies put in place when we speak about police forces, getting more in touch with the community, having more open dialogue, conversations, understanding the needs from both sides of the aisle. I think this is wonderful news, and New Haven is setting a standard that I hope other communities will copy as well. I presume it's free, like most nonprofit like ours is.
Yes, it's a nonprofit organization purely designed to make our community more healthy.
That's wonderful. I love that. Dr. Johnson, a recent Association of American Medical Colleges reports more women than men entering med school, and for the first time, after whites and Asian students, Blacks are in third place. Can we hope that as the number of Blacks in the medical professions improves, so will the quality of care for patients of color?
So I think that we have evidence to show that patients can be more compliant if they have a physician who looks like them. Now, that doesn't mean that if I have a physician that doesn't look like me, I'm going to be uncompliant. But when you're looking at communities who have a certain level of medical mistrust, you have people in neighborhoods that are underserved, that these make a huge amount of difference to the level of care and to the accountability of the patient in that way. In that sense, in order for us to increase the number of students who are going into our primary care specialties, or in my case, in radiology, there's been the development of pipeline programs to bring students in, to show them role models and to give them early exposure so that they can be a part of the community. I have the privilege of being the director of the American College of Radiology pipeline for the Enrichment of Radiology program. And it's a program designed to take women and underrepresented minority medical students going into their second year, and they spend their summer with us. The last 2 years have been virtual. This year will be virtual as well. And we expose them to all areas of radiology and radiation oncology, looking at patient care, looking at treatment strategies, looking at how radiology fits into all of the areas. And they do a research project and they get mentors assigned, all designed to let them have a positive experience with some support, meaning mentorship and sponsorship, in order and create role models so that many of these outstanding students are going into radiology, increasing our numbers and increasing the quality of care for some of our underserved communities.
Well, you've hit a sweet spot because with the Connecticut Women's Hall of Fame, we are all about role models. One expression is see it, be it. And that's what we do. We weave the stories of women's achievements throughout history and present them so that young women and girls and young men and boys can have role models to follow through. The National Institutes of Health data suggests that Black physicians view race more importantly than white physicians when making decisions about patients' treatment, medications, and risk of disease. You're a professor. Are schools teaching the importance of race in health and wellness?
Well, I think I alluded to this earlier. I think that schools are actually teaching more appropriately and broadly, that it's not just race. Think about something like breast cancer, where we now know that there are markers that we can use, biologic markers that will help to stratify how serious cancer would be, or the cancers that run in families related to gene expression. I think that what medical schools are teaching is it's not just race. It's not the color of your skin. It's a lot of factors that come into play. And that what I think and I think if we remember that, and I kind of coming back to take the individual where they are, you know, I'm a woman, I happen to be a Black woman, I am a professor at Yale, I'm a radiologist. If I made a list of all the things I am, that's more than just the color of my skin. And I would encourage the audience, the teachers in the audience, the students in the audience, is to think beyond the skin color and think about who the individual is and what they bring to the table to enhance the community.
Sound advice for sure. Dr. Johnson, February is not only Black History Month, but also American Heart Month. That's why I'm wearing red, focusing on cardiovascular health, your specialty. Reports show that only about 50% of women realize that heart disease is our number one killer. In comparison with white women, Black women have even more CVD risk factors, develop it earlier, and have higher mortality rates. Can you tell us why that might be?
So, I mean, I think, again, these are multifactorial. It's not just the color of the skin, if I can be repetitive. I think risk factors that you all know, your weight, your basal metabolic rate, how obesity is important, nutrition is important, exercise is important. Certainly your family history, your individual family history. Did your parents have heart disease? Do you have diabetes? All of those things can contribute to cardiovascular risk. And then I think that it's important that the audience recognizes, and it's not just the adults that are listening, but the students that are listening need to know that if you have chest pain, or sometimes in women the symptoms can be unusual, you can have abdominal pain, or you can have a cold sweat, or you can be short of breath. The symptoms are not just the elephant on your chest that you see on the television when they talk about, I'm having the big one, I'm having the heart attack. Similarly with stroke can be sudden weakness of arm, face, or leg. It can be difficulty with speech, difficulty with vision, trouble walking, dizziness, all of those things, and occasionally a sudden severe headache, which might relate to a stroke that has bleeding into the brain. So there are a number of symptoms that can come into play with cardiovascular disease and stroke, recognizing that when something happens that's unusual, you need to see it in your loved one who's sitting on the couch over by you, as well as recognize that you're having funny symptoms that you need to bring to someone else's attention.
So, Dr. Johnson, can we just stay on this subject for a little bit, because it's so good to have helpful takeaways. So can a woman, I've heard that, a woman might have the abdominal pain but could we also have the elephant on the chest?
Oh,
Uh,
yes.
they're,
Yes.
they're interchangeable. Could a
Well,
man
yeah, well,
have abdominal
not
pain?
so much that they're interchangeable, but depending upon the location of the injury to the heart, the symptoms can be somewhat different. Like I said, women can have heart attacks and not have the elephant on the chest. So, it might feel like indigestion, or it might be some sweating associated with it. So again, I think each of us as individuals, part of self-care and wellness, if I can go back to your original theme, is that we need to be mindful about ourselves and our bodies, and then at least we recognize when something is not right and bringing that to someone's attention.
And if a student watching or a family member, do you put that person in the car, go to the hospital, or do you call the 911 so the EMTs can evaluate what's going on? I find with friends of my generation, we're confused about that, what you should do in the event, because sometimes you're reluctant, oh, I don't want to bother anyone. And then other times you shouldn't go in a car because you'll wait and you should go with the ambulance. Any thoughts on that?
Yeah, you call 911.
You do.
You get help to you as quickly as possible. Remember, the 911 operator is going to stay on the phone with you. They're going to give you some instant advice about what you need to do. They're going to make sure that the help gets to your loved one, or to you if you're the one having symptoms and you're trying to communicate the best you can in your setting of illness, but you want to get help to yourself as quickly as possible.
Very good. Very good idea. Let's come around a little bit to Connecticut. We always like to finish our discussions and bring it home to our state. Connecticut health stats compare pretty well to other states. In 2014, the Office of Health Equity was established. However, accordingly, disparities persist, especially as Connecticut is highly segregated by income and race and zip code, as you mentioned. Your thoughts and maybe your New Haven experiences. I know we've talked about the Hope Center, which is obviously addressing some of these issues. Is there anything else we can say about the disparities across the state of Connecticut?
Well, I think the legislature is doing a good job. I am the diversity chair for the Radiologic Society of Connecticut, and the members of our committee have been meeting with the Black and Latino caucus, talking about such issues as breast cancer screening and tomosynthesis around the state, looking at opportunities to bring the screening to the communities where the patients are. There are some efforts in the state to, say, bring the mammography screening van to churches in the state. I think that these kinds of partnerships with medical practitioners and the lawmakers can be really helpful across the state and regionally to impact the care that our patients receive.
You mentioned another screening. I don't know what it is. Tomosynthesis?
It's a more detailed mammographic technique to be able to get more information, particularly in the dense breast.
Oh, so that's like the ultrasound that they do for
ultrasound. It's not ultrasound, but it's just another one of the arrows in the quiver of technology that radiologists have in order to be able to evaluate disease.
So based on what you're saying, the topic of Black health and wellness is prevalent in medical communities, and they're joining with other movers and shakers in the state to make a difference.
Yes, I do think that that's the case. I think that we are bringing some of the healthcare disparities to the light of day. I think has made a difference. I think from my perspective as a radiologist here in Connecticut, there's a lot of things that we do to affect both diagnosis and treatment of our patients. It's been very important to me to work within the community, taking care of patients with stroke and aneurysms over the years. And I think that it's a responsibility to come back full circle and do these kinds of educational outreach programs to provide example for others, and also to hopefully reinforce the issues that it's not just the color of your skin, but the content of your character, to quote Martin Luther King, who said that so wisely.
He did. I want to remind our guests to ask questions. We're going to be coming up on the question and answer period. So if you kindly put them in the chat or the Q&A box, I'll get to them as soon as possible. Dr. Johnson, for today, I Googled, which I do a lot of, Black women's health and wellness. And I encountered pages of initiatives by women of color, from everywhere from Shondaland to celebrity influencers to top-notch nonprofits. Much of this focus was on self-care, with noted authors stating that self-care can also be a tool to counter the effects of systemic racism and trauma. What would you say to that?
So I kind of have a concept that through self-care, you strengthen yourself, you strengthen your spirit. And self-care could be a variety of things. It could be meditation. If you do that, it could be going regularly to the gym 3 days a week, whether you want to be there or not. It could be eating a healthy meal on at least some periodic, if not a regular basis. It could be talking with friends. It could be talking with colleagues at work. But whatever that is, that fuels your soul, if you would. I think what that does is it makes you stronger, so that no matter what the adversity that you experience, you're a little more ready for it. The catchphrase now is resilient, but I think it makes you better able to move forward even when things aren't perfectly aligned.
Healthy and strong. As a guest speaker at a medical conference in December, where much praise, deserving praise was given to you, you said, and I quote, "Relying upon one's strength when confronted by adversity is important, especially when dealing with those barriers that are tangible and difficult to overcome." How have you and how can we apply that advice to health and wellness?
So I think that in that talk, my job was to talk about how I got to be an interventional neuroradiologist as a Black woman, and what things I encountered. And I think that it was important in that to be true to myself, the woman I am, or the woman I want to be. And then to realize that sometimes you're going to hit a wall that you can't go through. Sometimes you can go under it, you can go around it, you can, like the kids song. But sometimes you can't get past that barrier. So then you have to learn to pivot. You have to say, okay, well, I'm not going to get that job I wanted. So let me look at what else I might want to do. And maybe you'll end up finding something that you want even more than that thing you thought you wanted. Or maybe you find another alternative that you hadn't thought of before. So that barrier can in fact be an opportunity if your mind is receptive to take that opportunity and run with it.
When you're teaching, just before we end, can you tell us anything about what you find in today's students that maybe is new and different than in students in your past experience? I mean, you've been doing this quite a while, and I'd just like to know how you view people coming into the medical community in 2022.
Well, I think there are differences, and I've been really interested in the generational differences, the things that my mentors who talk to me, and we'd sit at a reading station looking at images and talking about our cases. And, there's been a period through COVID where we might be remote from our trainee, and it takes some innovation to communicate.
Mhm.
And going back to you've got to take people where they are. These are people who are maybe younger than your kids. They are going to look at things differently. They're going to hear things differently. So I think it's very important to listen to others. And I many times will say to them, I'm going to try to teach you this the way I think of it. But if this doesn't, if you're not learning from the way that I'm teaching, then I need you to communicate how you learn. Some people learn by doing, some people learn by reading, some people learn by hearing. So some people are real visual learners and some people are auditory learners. So I think you can work with the individual to create a learning environment that's positive for both, because it's wonderful for a teacher when the light bulb goes on over your student's head, like like the cartoon, and you think, oh, I got that message across. But you can only get the message across if you create a rapport to be able to do that. And I think that's very, very, very important now with Zoom and these more remote learning environments that we have by necessity taken on.
But I imagine you will welcome the day when we can get back to in-person classes, right?
Yeah, I think the in-person class is super important. I think it is a tangible experience. I also think that the opportunity for Zoom learning means you can have, like this afternoon, I could have a lecture by somebody in Australia who can be talking to me over Zoom. We've done a lot of grand rounds with people from different countries. Last Friday, we had a neurosurgery professor from Italy speak to us. So there are some real opportunities that have come with the new technology, just as there are changes that are related to not being able to be in person. So I think that at least I'd like to hope that the best of both will ultimately be options, and that we'll shift our teaching and learning styles according to the medium that works the best for a given type of education.
And the catchphrase these days seems to be hybrid on all fronts. So we're going to take a couple of questions. So the first one is, would Dr. Johnson speak to the issue of stress and trauma on health, if she is seeing more of any of this since COVID hit?
So I'll just say again that I'm a radiologist. I deal with emergencies like stroke and bleeding in the head, but I also deal with patients with headache. And some of the patients with headache have a cause that you can do something and fix, and some of them have a headache that medication will work for. I think that stress-related illness is real. It's tangible. I think that it's also something that was sort of the quiet thing that made people sick, that I don't think we realized until 2020, that this was making people overeat, making people undereat, making people sick. The stress of worrying about COVID or worrying about family members or not being able to see other people. And so I think that the incidence of stress-related illness probably is up. I think it would be the psychiatrists that would be seeing the part that you would think would be most stress-related. But I think that on all areas of medicine, stress impacts how you feel in it, and how much you weigh and how you deal with illness. So I think stress is here to stay also, I think.
And it's interesting because this seems to be the topic on everyone's mind. The next question is, from 2020 to 2022, we found ourselves facing mental health needs. Without addressing this, I envision more heart problems and circulatory problems. Would you agree with that?
I don't know that I have the data to say that. What I could speak to is, at least in a short time, where there were early in COVID, there was a concern that the increase of stroke rate was higher, and there were those cases of young women who had blood clots in the brain. But those numbers, that didn't really have to do with stress, and that the overall numbers of stroke patients during that time frame was not so different. So I think that the data is still unclear, and I don't think I could really speak to the overall incidence of stress-related illness. It's just not my subject matter area.
We'll be looking for that data as you and I spoke earlier today. It seems like a long time we've been in COVID, but in terms of amassing the data and the results, 2 years is not that long.
Absolutely.
Here's another question. Do you feel that patient care has suffered through virtual patient care? We all have these telehealth appointments now.
So I think that in many ways, telehealth, after you get over the barrier that not everybody is tech savvy to be able to use the programs, has actually made healthcare more accessible. Because in the time frame that you can see a patient physically, you can more efficiently use the telehealth. Now, it has its disadvantages, right? There are times when you need to lay hands on a patient, you need to listen to their heart, and you need to do some things that you can't do on a video visit. But I think that the patients that might have waited 6 weeks to see a physician that's a subspecialist, that's not me in radiology, but a subspecialist that they need to see might wait 6 weeks. With the advent of the telehealth visit, those waiting times are shorter. And so they can get their problem to the physician, and then when that needs to be converted to an inpatient or an in-person visit, that can be done more efficiently. So I really think that that's another place where we'll have hybrid care, that both things will live to be here in the future.
Exactly. And sometimes it's easier to get a telehealth appointment than it is to get an appointment, and you get your question answered pretty quickly. And if they need to see you, then you go in.
Sometimes you can get a same day or next day telehealth appointment.
Exactly. So this is a lengthy subject, but I would feel remiss if I did not bring this up to you, Dr. Johnson. This is from Jan Kritzman. I am a 9.5-year breast cancer survivor. I became well aware during my treatment that young women of color in their 20s, 30s, and early 40s were affected at younger ages than Caucasian women with breast cancer, oftentimes with triple negative, which is the most difficult to treat and at a late stage. I've taken it upon myself to champion breast cancer legislation in Connecticut, both in 2019 again in the current legislative session, to afford both insurance-mandated screening and diagnostic mammograms, ultrasounds, and MRIs with no out-of-pocket financial barriers, no cost sharing, no copays, no co-insurance, and no need to meet deductibles. In the last legislative session, I suggested that breast self-exam be taught in Connecticut public schools as part of the health and sex education curriculum. This became part of Public Act 21-35, Section 14. Breast health education needs to start in middle school through high school. What would you say to all of these efforts? And Jan, congratulations and bravo for working on the benefit of all women.
So Jan, that's amazing and wonderful. We've been working on a task force for breast cancer. Again, as a radiologist, even though I'm not a breast radiologist, I'm a woman of color who lives in New Haven. So I'm there representing the community and being able to look at how the Radiologic Society of Connecticut can assist the legislature in understanding the tools in the radiologist's quiver, understanding the issues of breast cancer screening, as I mentioned earlier, bringing the screening to the patients, such as coming to a Black church with the mammography screening van. I think all of those efforts that you've mentioned are incredibly important and things that we as women in Connecticut should be working towards and supporting. So I applaud the work that you've done.
I second that. And now for our last question, and I'm not sure, Dr. Johnson, if it would pertain, but maybe you have some knowledge. She writes, emergency rooms have been overflowing. Do you find you're seeing your patients soon enough overall?
So there's no question that emergency room census is up. And in terms of, from my standpoint, in terms of seeing patients, it's with imaging. Emergent imaging gets done emergently. Elective imaging can be delayed because everything is back in the hospital setting. The hospital census is high. The emergency rooms are very busy. And I think that our nursing staff that does the triage to when you come into the emergency room and they ask you those questions, they're trying to determine the acuity of your illness and who needs to be seen first. And so the importance of triage, the importance of that communication between healthcare providers, I think is critical to the expedient care of patients when they arrive in the emergency room.
Thank you. I lied. One more question. I don't want to leave any unanswered. Dr. Johnson, do African Americans suffer any higher incidence of AVMs than the general American population? And how does our population support cyberknife interventions? I don't know what AVMs are.
Okay, so AVMs are arteriovenous malformations, and I presume that the questioner is asking about the brain, since the brain is what I do. And so these are abnormal connections of arteries and veins within the head with no capillaries in between. And these AVMs may be asymptomatic for an entire life, or they may bleed and the patient suffers a hemorrhagic stroke. They can be treated by a combination of treatments over my career, surgery by itself, embolization, which is when we put a small catheter into the arteries of the brain and inject an agent to block those abnormal connections, often followed by surgery or cyberknife. The other tool is gamma knife, and both gamma knife and cyberknife are radiation oncology or radiation therapy tools to apply a high dose of radiation to the area where the abnormal connection lives. And so there isn't a disproportionate number of African Americans with vascular malformations as compared with Caucasian Americans. There are some familial types of vascular malformations that can happen, as we talked about, families that have things, not just people of color or people not of color. And I'm not remembering the actual question about the cyberknife or gamma knife, but that can be accessible for AVMs of a certain size in relationship to the size of the AVM and the brain that's adjacent to it that could be injured by the radiation. So I don't know if you have a follow-up or if that answered your question.
Well, I can say that when we go overtime, I know it's a really good chat, and we are overtime. I want to thank you again, Dr. Johnson, for being my guest today. And I'd like to thank the William and Alice Mortensen Foundation and AvidGrid Foundation in partnership with CNG, SCG, and UI for supporting this series. Today's presentation, like all our webinars, will be uploaded to our website, cwhf.org, within a day or two as part of our educational programming platform. At the top of our webpage, you'll see what we do. Under that, you'll see webinars. Click on, and you can see all of the webinars up to today. Once again, many thanks to you, Dr. Johnson, for this important and illuminating chat in honor of Black History Month. And I hope you'll all join us in March, Women's History Month, for a special presentation. Look out for that announcement soon. Thank you again. Goodbye, everyone. I hope you have a great rest of your day.
Thank you very much.
Thank you. We'll talk soon.